Hey, how's it going?
So it's going well. So Dr. Marina Ivanchich, we didn't cross paths, but we did training in Philadelphia at UPenn. I think you were before my time.
Oh, so long before
I
you.
think
You're
you
just
were.
you're just a wee nugget to me.
Yeah, I think you were before my time. But Marina is big into the zoo and marine mammal um, radiology. I don't know, Marina, if you want to say a little bit about yourself, but
I
I
mean,
thought not really.
not really, not really. I mean, I was just gonna say, yeah, I think you and I met at a ACVR conference through some
Yes.
mutual friends, is how I recall, and like I just immediately hit it off the bat, right off the
Mhm.
bat, and hit it off. Yeah, so yeah, we never actually had a chance to work together, but we're both relatively silly people who know a reasonable amount about radiology. So I think that's why we decided to try this out.
Yeah, and I don't think we're not going to do any porpoises, right? Or killer whales.
We could do, but not today.
No,
No,
no.
I think you got to know your audience, right? So I think
Yes.
everybody online is probably a cat and dog animal person, and if not, let us know.
Yeah. So we're gonna do a couple of we'll do a couple of known cases. We'll do some unknown cases. We've had two cases from folks that joined last time that wanted to see kind of what we thought, cases that kind of troubled them. So maybe what I'll do is I will start with. All right, so this is we've got two JPEGs. The signalement is it's like a 10-year-old large breed dog. I think it was like a Labrador that had presented for coughing, and so I think it was coughing and lethargy. And the requesting doc got some follow up on the case through cross sectional imaging and some histopathology. But my guess is she wanted to present this so we could see maybe what we thought. We'll see
Okay,
what
so you got the pneumonia, right?
we've got. Some pneumonia. We've got a
Question
boat.
about a huge spleen.
A huge,
Um,
huge spleen here. Huge spleen. Yeah, I mean it could be.
could be
Could
a
be.
little cut off there.
So here's kind of what I don't know if the doc that sent this in, she's come the last few times, and so I don't know if she's on or if she's just kind of keeping mum. So I kind of knew what became of this dog. But I think what Ure is pointing out is this issue that we've got in the left cranial lung lobe. So I think that what I see is there's abnormality right here, which is a right lateral view, and so you're going to see the left cranial lung lobe predominantly. And so the thing that caught me off guard, or I think that you should kind of keep an eye out, is that there's a stippling of gas bubbles. So there are sort of irregular gas bubbles, and that's very weird, I think, for like a pneumonia case. Um, this looks mostly like an underinflated left cranial lung lobe. So the right kind of does the old, I think we could say the old reach around, and then the left cranial lung
Oh
lobe kind of
boy, oh boy.
comes up here, and this
All
left
right.
cranial lung lobe is a bit underinflated. So my guess is the doc that submitted this wanted us to kind of say that we didn't see what it ended up being, which this ended up being there was a mass in that left cranial lung lobe that they took out, and it was a carcinoma. And I don't think I wouldn't say that there's a mass in this left
Hmm.
cranial lung lobe. I think what I would say is that there's an alveolar pattern with some irregular gas pattern, and that's not normal for pneumonia unless you had like necrotic pneumonia. But even then, I would expect maybe I mean, like really bad necrotic pneumonia, sometimes you get pleural fluid. So with this particular case, I wouldn't have had any concern based on this that there was a mass other than the abnormal gas pattern. So the abnormal gas pattern, you could think about migrating foreign body. You could think about a necrotic tumor, but I don't see a tumor. So in this particular case, I think a thoracic CT is what they ended up doing. And they saw what looked to be a poorly defined tumor, and part of it was necrotic. So I
Hmm.
think for me, this wouldn't have been straightforward pneumonia. I think the abnormal gas pattern would have pulled the trigger to do cross-sectional imaging, CT. I think you could try to ultrasound the cranial thorax, but all that gas is going to make it, the back fat and the gas is going to make it challenging. So CT is great for this case. I
I
don't know
have
if you,
thoughts. I have
what are your,
thoughts.
let's hear it. Let me back up. Here we go.
Yeah, I was like, don't make it small. Let's not shrink it up
No.
on me. I'm about to say something. So yeah, I mean, I concur basically with everything Peter's saying. The kind of bubbly looking gas pattern there too also makes me think a little bit of lung lobe torsion because you can get those little trapped like
Mm,
emphysematous.
mm,
Oh, Dr. Allen was saying, can you see that on the VD?
mhm.
Oh, the gas bubbles, like maybe if you zoom in, yeah, perhaps. I don't know. I can't see it. Like can see some little gas lucencies in there on the VD. But I
Yes.
can't tell if those are air bronchograms or if those are like emphysematous bubbles like we see on the lateral view. And then, of course, if you're considering lung lobe torsion, then you have to look for other Rankin signs, such as, is there pleural effusion present, especially on that side? Can you follow any of the bronchi to see if they are coursing in an abnormal direction, etc.? So that was just something I wanted to throw out there too, as like, pathology in the lung that can cause that bubbly looking focus. I'm always down for cross sectional.
I've got a case of, I think I've got a lung lobe torsion that I wrote down that we can maybe see to compare it with this, which would be great, I think. And yeah, the gas pattern she's referencing is typically we call it a vesicular gas pattern. And so in cases of acute lung lobe torsion, you will get a vesicular gas pattern. The one thing that made me relax on the torsion in this particular case, usually with the vesicular gas pattern, the lungs expanded. So you cut off the venous drainage by the torsion, you continue the arterial influx, and then you get the stippling of gas. So the lung gets kind of big. And in this case, it's kind of smaller. And then with a chronic lung lobe torsion, sometimes you lose the bubbling. But yeah, definitely the bubbles with lung lobe torsion, migrating foreign body, but usually migrating foreign body like torsion, like Marina said, you also get pleural fluid. So kind of a weird case. But I wouldn't have. I think the take home for me, and maybe the reason the doc reached out, was I don't see a mass. What I see is an abnormal gas pattern, and that's not a common thing for pneumonia. And so you would, I think, want to go towards cross-sectional imaging sooner rather than later.
I would also add to what you're saying, Peter. Sorry, not to like harbor on like one case for like the entire hour. Is I think it's important to recognize that you do have an alveolar pattern on the ventrodorsal view, and I don't appreciate a huge mediastinal shift, like a big swing to the left, suggestive of a significant volume loss in that side. So I think if you just had that one projection, that VD, an argument could be made for no mediastinal shift, and therefore that would be more likely to be pneumonia just based on that one view,
Yeah.
without that added information. So I think I don't know what the process is. Do you guys go through like what are your findings in the description, and then like what do you think the diagnosis is? Or are we just throwing out like hot takes? Like, is this pneumonia? Is this a cancer? Is this
Yeah, I mean, I think in this particular case we know the outcome. Some of the other ones we don't. So I think it can
Got it.
be a little bit more open to differentials. But in this
Yeah,
particular case, she hasn't joined. Um,
got
but
it.
she sent it and kind of said, look, I think it was more, did I miss something? Should I have done something differently? My guess is, and I don't know this, but my guess is maybe there was a protracted treatment for, maybe this was like the first radiograph they took, and there was maybe a protracted course of pneumonia treatment.
Antimicrobials. Yeah,
Antimicrobials, the dog
antimicrobials. Yeah,
didn't get better, got worse. Then they CT'd it, and then they go, oh shit, we've got a mass. So
right.
I think for me, the big thing is the stippling that you see here, not normal, not a common thing for your run-of-the-mill pneumonias. You should probably get on cross-sectional imaging faster, and doesn't
Love it.
have the other features that we talked about that would make you think it's definitively a lung lobe torsion, definitively a migrating foreign body. So,
Right.
okay, let's see. There's another case that was brought that we don't have. This is exciting. I like when we don't know what's going on. Okay, so this is, let's see. So this is it's JPEG, so we can't do a whole lot. I think I've blurred out all of the necessary information so we don't give anybody away. There are 4 views of the PES, and I don't know. I think it was the right PES. It's all the same all the same limb. Okay, and the dog's limping, and he's an older dog. So I don't know. We could maybe. Am I muted? I don't think I'm muted. No. I think maybe we could just see if people have some before we point out. Dr. Allen. Soft tissue swelling, distal metacarpal 3 lucency. Mm-hmm. Here's what we've gotten some feedback. Carpa. So I'll show you. We've gotten feedback that it's been beneficial to see how we go through the process of interpreting the radiograph. So Marina, she can talk to maybe how she would do it. But musculoskeletal for me, you have to be very systematic so you don't miss anything. And so I'll just show you the way that I go through this. So I look at the digit, P3, P2, P1, and then I just do this and I stop, and then I go up here and I go up here and I stop. And then I look at the palmar sesamoids back here. You got 2, 1, 2, 3, 4, 5, 6, 7, 8. Okay, and then I look at the metacarpal bones, and then I look at the carpi, the carpus rather, the distal antebrachium, and then you don't want to forget about soft tissue swelling. It's kind of like it's I think often you get so focused on the mineral opacity, the bone, that you kind of miss. So the carpus right here, the carpal joint, the right carpal joint, to me does not look swollen. Abductor pollicus longus. Sesamoid, but as our astute little team has picked up on this right here. So 1, 2, 3 metacarpal bone. So in the distal aspect of the third metacarpal bone, I do think that there is an aggressive bone lesion. And remember the features of aggressiveness, you only need one of the 3. And in this particular case, the one can be an irregular periosteal reaction. This periosteal reaction isn't super irregular to me. This is probably an enthesophyte, kind of getting close to an osteophyte. So osteophyte, joint margin, enthesophyte, soft tissue attachment. Maybe it's not immediately next to the joint. So just so everybody knows, this is what we're looking at right here. This nugget right here, not uncommon for, I've seen it a lot. A lot of times you'll get either OA or enthesophytosis related to these metacarpal phalangeal joints. So this isn't necessarily what's bugging me and probably bugging some of the other folks. It's this right here. So the feature that I don't like is that there looks to be some medullary lysis and the zone of transition is indistinct. So that's the feature of aggressiveness. So, and it's nice that you can use these other metacarpal bones as an internal control. Maybe the cortex here is a little thin, and that's some smooth periosteal reaction. Palmar metacarpal phalangeal 7 looks like maybe it's got a couple of friends right here, which is not always the end of the the end of the world. Maybe that digit's swollen.
A little like bipartite sesamoid or something like that.
Yeah.
No one cares. No one cares.
No one cares. 2 and 7. I think those are the ones that get it. Rottweilers.
2 and 7.
2 and 7. That take you back?
Every time you say something that I already know, it just gives me this amazing feeling of like I didn't make this shit up. Like
no,
it's so validating. Yeah, because when you practice on your own for a long time, you think you start to like make up your own shit, and then somebody else says it, and you go, oh, or like a student will like fact check you in the moment on Google, and they're like, oh, really, that's true, and yeah, it's so exciting. But
so you fact check me, I'll fact check you. This looks swollen. Yes. I don't know if anybody else thought that.
That's the first thing I noticed.
Yeah,
that was the first lesion that popped out at me. Was like when you were saying, don't forget to look at soft tissue thickening. Which I was trained to say thickening, not swelling, and that's the first thing I do. And I'm not particularly systematic in the way I review anything, which is not something to take on. I don't encourage that approach. But that's the first thing that I do is look for soft tissue thickening anywhere. Or conversely, like atrophy, of some of the soft tissue, musculature, et cetera. Not so much in a PES where we don't really have that much soft tissue and musculature to look at. But yeah, anyway, go ahead, Peter. That was the first thing that popped out.
Well, yeah, and I think the other thing that I've been tricked on before is you have to watch the orientation of the digits. Sometimes they will, the patients will, you just have to be careful if this is going and maybe if you're trying to use this as an internal control for that looks swollen, and everybody, this looks like nobody else at the party. You got to make sure that it's not being explained by maybe it's rotated or the nail is caught and it's being flexed in an unusual position. But I think they did a good job of actually getting this on a, how do you do this freaking thing? I think that digit is probably the third one, and that looks a little bit upset. So
I think 1, 2, 3, 4. 1, 2, 3, 4. Yeah, that's 4, isn't it? The one you were just circling? Yeah. 4. Okay. Yeah. Sorry, I thought you said third one, so that was confused.
Oh, sorry. Yeah. No, I think you're right.
I think it's 4 on both. Yeah.
Yeah.
But they did a beautiful job splaying out those digits. I can't say how often I see that, which almost never. I get a lot of the superimposition, a lot of this action, and then you're like,
yeah,
that's as useful as a
Well,
flavored lollipop. If people, the latter, right?
Well,
I mean,
yeah, and this one, I think that aggressive lesion is probably hiding right in here, and so maybe if they if they did a little bit more of an oblique, we could see it. But to me, the differential for this would be potentially a primary bone tumor, like osteosarcoma. It could be. I know they'll get a lot of squamous cell carcinoma and melanomas, like the digits, but I usually see those as sort of obliterating or causing lysis of P3. I think it could be, other things, I guess, to consider. I saw a little bit of swelling here, and there's a little bit of periosteal reaction. Sometimes if you have a soft tissue injury, like an abscess or some sort of infection, it can cause an osteomyelitis, but I feel like that tends to cause more irregular periosteal reaction and not this is always what happens to me. I read a comment and then my brain just goes.
I know. Yeah, you derail from what you were already thinking about. But you were discussing infectious.
I think it could be an infectious thing. Yeah. I mean, I don't see why not.
I think a MET is also possible. A metastatic lesion can do this. So under the category of neoplasia, which you were talking about, Peter, like the squames and the melanomas and stuff that can involve P3 plus or minus P2.
Yeah.
I think a metastatic lesion, I mean, I don't see those commonly, but we were trained to always consider that as a differential for an aggressive lesion.
Yeah, I like that. Infectious disease. Sometimes you get like a migrating foreign object, if the dog's out and it gets something, then maybe you get reaction from the soft tissues into the bone. But I think that it's usually, I mean, when I see it, it's usually the periosteum is pissed, you get spiculation, and you're like, oh, there's an aggressive bone lesion, but there's a ton of soft tissue swelling. This, to me, there's not a ton of soft tissue swelling. It seems to be mostly bone. What else? Amelia said 2 lesions. Is it polyostotic? My guess is no.
Right.
I would guess no. My thought is, I don't know. Did he stub his 4th digit and say, "Look at me, look at me, look at me"? Maybe he's limping already, and jammed it, stubbed it. Maybe there's a dermatitis in this digit. Maybe I think it's probably unrelated. But I don't know, man. We don't know. So biopsy, right? Chest rads biopsy.
Yeah. Yeah, sounds good to me.
All right, next case. Sweet. Okay, this is a hard one. I'm going to just say that right now. I think this is a very difficult case. Maybe not. Maybe you kind of stumble into it, but we're going to give you maybe a minute and a half. This is 3 views of a thorax on a fat, cute old dog. I don't know the breed. Probably doesn't matter. Could matter, but I don't know if it matters. 3 views of the thorax. We're going to start it now.
Sorry, did you say the history, Peter?
No, I didn't. Yeah, I didn't.
Okay, great.
Good.
That's great.
Yeah. So good luck. The history is, should we make it up? Is tachypnic and coughing. And yeah, it's like coughing.
Okay,
it's been kind of going on for a little bit. It's worse. The owners were out of town. The dog walker noticed that the dog had collapsed and rushed.
Dog's name is Miffy. Yeah, I got you.
Yep.
SFU, small, fluffy, useless.
No, I have 2 Chihuahuas, so
I love small, fluffy.
I take offense to that. No, I'm kidding. Okay, here we go. Anybody need more time? Want more time? It's 3 views of the thorax. There's
okay, that last one. Can you go back to the lateral you were just on?
Yeah.
It's a little bit of a chabdomen. Can we talk about chabdomen for half a second? So a chabdomen, and then I'm going to put up Dr. Allen's comments. The chabdomen is neither a chest nor an abdomen. Mm-hmm. So this is a pretty classic chabdomen. People get worked up and they say, oh no, the whole body is nice. The whole, the chest and abdomen in one view. I have no issue with the chest and the abdomen in one view. Totally okay, especially with digital stuff. That's fine. But this neither includes the whole chest nor the whole abdomen. So a chest by definition has to include the thoracic inlet, and an abdomen by definition has to include the pelvic inlet. This image has neither. I had to point it out.
So are you going to ask the tech to retake this rad?
I'm going to punch somebody in the ovary because this is not.
No, I'm going to let it go because I think I know.
don't like it.
I think I know.
It's fine. There's a ton of information, but
and we didn't get any real follow-up. No, we have follow-up. There are different, perhaps more invasive tests to figure out what we know. But spondylosis, diaphragm intact. Yep. The cardiac silhouette is enlarged heart soft tissue fluid opacity on the right lateral view. Okay, good. Unstructured interstitial pattern diffusely. Okay, so I love this case for a couple of reasons. The one reason I love it is probably the reason that nobody else is going to love this. But this opacity right here, I want to talk about this opacity. We could spend the next 30 minutes talking about this opacity right now. You know for sure without having another view that this is not in the chest. And the reason that you know that this is not in the chest, right? So you pull this up and you go, oh shit, we've got a pulmonary mass, but this is not a pulmonary mass. And the reason it's not a pulmonary mass is because this border is very distinct, but you don't see any other border, which means, for those of you that have kind of stuck around for the past couple of weeks, differential attenuation. So the X-ray hits these different structures in the patient, ultimately creating differences in attenuation when it hits the detector down below. So this border is outlined by gas, and that's why we see it so sharp. This border is not outlined by gas, and the reason it's not outlined by gas is because it's not in the lungs surrounded by gas. It's attached to the skin. So this is a thoracic body wall mass. So don't call this a lung mass. You can see it right here. It's moved up a little bit higher, and if you kind of window and level it, you'll see it right here. So it's a left lateral thoracic mass, probably a lipoma. We're not going to worry about it. So the cardiac silhouette's too big. I think that the dog has left-sided cardiomegaly. The caudal waist is sort of flat. The thoracic trachea is deviated towards the thoracic vertebral column. Maybe get a left auricular bulge. There's probably too much opacity here. But I think this dog also actually has right-sided cardiomegaly too. Very, I feel like, uncommon. I think 9 times out of 10, every time I say cardiomegaly, it's left-sided. But I think the one thing for those that haven't been here, when I see a lung pattern, I'm going to draw this obliquely through the cardiac silhouette. And can people tell me if they think that the lung pattern is worse cranial ventral or caudal dorsal? Dr. Curtin. Dr. Lucy joins us a lot of times, and I think she's going to get it right because she's always on this stuff. Caudal dorsal or cranial ventral in this view, what do you think's worse? Anybody?
I got my hand up, but I'm trying.
Oh, gee, okay.
Oh, Jesus. Yeah,
oh,
sorry.
jeez. Okay. So since nobody's biting, what do you think? Caudal dorsal. Yeah, man.
Yeah, look at that.
So caudal dorsal. So if you see a lung pattern and it's worse caudal
Beautiful.
dorsally, I think you really should think 2 things. Based on just how common they are, you should think it's either cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. So if you have a cardiac enlargement, you should prioritize cardiogenic pulmonary edema. If you have no cardiac enlargement, you should perhaps prioritize non-cardiogenic pulmonary edema, the caveat being like a ruptured cord. So this particular patient has cardiogenic pulmonary edema, but it's actually from pulmonary hypertension. So you'll get a sildenafil responsive pulmonary hypertension from dogs with chronic pulmonary hypertension, and they can get a little bit of oozy edema in their lungs. I don't expect or think you should pick up that on this radiograph. I think what you should probably realize is that there's a caudal dorsal lung pattern and the cardiac silhouette's too big. And you hit it with Lasix and you get an echo, and they'll tell you that it's pulmonary hypertension.
I got to jump in.
Yeah.
Because I can't be stopped. So check left atrial enlargement, right cardiomegaly, dorsal dorsal displacement of the carina. Check increased sternal contact, right-sided heart enlargement. Check caudal dorsal, dense interstitial to alveolar pulmonary pattern with loss of conspicuity of fine pulmonary vascular detail. You're almost obliterating that descending aorta. Only thing I would add to that is I was taught, I don't know, it was beaten into me. You are not allowed to say anything about the heart without immediately afterwards commenting on the vessels. And it doesn't mean that that's going to change your differential, whatever. It's just like, it's like heart vessels. It's like if I don't know, the first thing I say about an abdomen is whether or not it's distended and whether or not the serosal detail is normal. So first thing I say about a chest is basically whether, I talk about the heart and then immediately, boom, I hit the vasculature. And the first thing that hit me when you put up these films was, yes, the cardiomegaly. And then what do you guys think about the vessels? I don't know if there's like too much of a time delay, if we like wait for people to respond. but to me, like those vessels are extremely X, and I'm trying to figure out if you guys can see what I'm trying to say, whether they stand out to me as being like exceptionally either big or small. Um, okay. Oh,
They're
yes, Dr.
small.
Curtin. Yes, Dr.
Curtain.
Curtin. Yes. I love chest and abdomens too. Musculoskeletal. We were just talking about this earlier today, Peter.
Yeah, but nothing like a musculoskeletal case to slow me down.
Right. That's right.
So,
Especially if
and
it's on a chimp. Okay.
and yeah, and folks like Dr. Curtin don't like him, and so she's more likely to send them. So we appreciate that. Thank you for clogging up my list with they seem small to me.
That's right.
They're small. Yeah.
That's right. That's
One of the caveats that I'm going to throw out for your pulmonary blood vessel tangent is the possibility in a telerad setting of them hitting the dog with Lasix
always.
and then sending the rad and then not telling you about the Lasix, and then you're
Always.
like, why is why is this not fitting?
Heart failure, small vessels, you got to think Lasix. Absolutely right.
Yes.
It's almost like you've done this before. Is this your first day? Look, you're doing well for such a youngster.
It's easy though, but what's easy is when I know the cases, right? So let's do this. Here we go. Let's click this one. What are we gonna get?
I'm just putting up Amelia's last comment.
It's gonna be 3 views of a skull, and oh boy.
Oh boy, are they gonna be perfectly straight? If not,
Boy, here we go. All right, let me
wait, Peter.
Yes. Yeah.
Dr. Noël. Dr. Allen was asking about vasculature, since I was harping on pulmonary vasculature, always commenting on whether they're big, small, or normal. Yeah, sometimes when I see a big heart like that, I wonder, and either small or normal vessels, I do think about use of diuretics, prior to acquisition of images. I do think of pulmonary hypertension as well. So yeah, I think that's a reasonable thing to consider, those two options.
The other thing that I want to make sure too, I think we've got some vet students, so I don't want to assume. I think there could be a somewhat of a broad gap in knowledge and experience, and so I don't want to be redundant, but I also think it could be important to just point out some of the more fundamental things about a radiograph. So this is 3 views of an abdomen. Maybe, what do you think? Let you look at it? You want me to just walk you through it? What do you think? What do you think, Dr. Marina? What do you think?
Dr. Marina,
third year vet student.
How are we in terms of time? Ooh, third year vet student. Okay.
Third year vet
Great.
student. She's from Purdue. I don't know if you know where that is, but that's.
I was at Purdue recently and did a CT on the head of a whale. Yes, I did.
Why was the whale? The whale is dead.
That's right. The whale was no longer attached to its head, but neither here nor there. So I went to Purdue like in the last couple of months and was so impressed with their facility and the radiology department.
Mm-hmm.
Shout out to Purdue.
Mm-hmm.
Whoop whoop, because I'm within driving distance. And she wants to be a radiologist. What a winner! We have to hang up on everyone else now and only focus the rest of rounds on Alexandra Meyer.
Well, soon to be Dr. Meyer. What we're going to do is we're going to convince her to join us in the studio next time.
That's right. That's right. Okay, go.
I'm going to just tell you through. I'm just going to walk you through this. So this animal is a cat. We know it's a cat because it's got its long lumbar vertebrae. Where did my history go? Let's see. It is a 4-year-old feline. It's a male cat. And the history: diarrhea. Been having diarrhea this Saturday, in and out of the litter box more frequently. Had one bout of incontinence yesterday. Nice. Owner says it could be possible the pet ate leaves from a house plant. Housemate's more likely to eat the plants. No other history. That's okay. All right. So Marina would have the technicians retake this view.
Not if they submitted an abdomen.
I don't think Marina has ever taken radiographs. All of hers are dead. All of yours are dead.
Absolutely not the case.
Okay. So big old fat cat, right? Falciform ligament, which is an extraperitoneal structure. Okay. That's not in the peritoneum. Those of you that do surgery, you'll notice that big hunk of fat. This is a turtleneck and this is an obese cat. So warming up the insulin. Cardiac silhouette's fine. The trachea's fine. Make sure you look at the cardiac silhouette. The liver right here, okay? Soon to be Doc Meyer. That's the liver. That's normal. Here are the kidneys. That's not a third kidney. They're superimposed over one another. That's the right. That's the left. They look fine. He's in the litter box. He's incontinent. He's doing all this stuff. You know, there's this whole, is it constipated? Is it urinary stone? So you want to look here. Urinary bladder small. You don't see any calculi. You can follow the urethra. You can hallucinate through there. It's fine. The colon's here. A little bit of fluid, a little bit of gas, a little bit of mineral chunks. Splenic head. That's fine. Left kidney.
The dorsal extremity, if you will.
The dorsal extremity.
The craniodorsal extremity.
Oh,
I'm sorry. I'm I'm that guy.
What did I do?
Guy. I refuse to call it head, body, tail, which is what 99.9% of veterinarians do. Please continue. Continue.
The splenic head.
Craniodorsal extremity. Yes.
The cranial and dorsal extremity of the spleen. The stomach has stuff in it. It's got some I would describe this as the stomach is mildly distended with a small amount. Well, I would say the stomach is distended with a small amount of content that includes a mixture of amorphous soft tissue, gas, and small mineral fragments. And then I would say, period. Some of the small intestine contains gas stippling. Maybe, you know, there's a couple of mineral things here. But remember, the small intestine, we talk about size, course, and content. Size, everything looks like they're the same. And they're not overly distended. The content, some mineral chunks, some stippling of gas bubbles. So to me, this looks like the cat's probably got some diarrhea. The stuff in the stomach, I think, is interesting. There's no vomiting, so I wouldn't panic about foreign material other than the mineral. So the mineral is not supposed to be there. Is it litter? Is it something else? We've had some questions through email about how do you decide gastric contents? What do we do something about versus what do we not do something about? I would absolutely do nothing about this stuff. The mineral is fine, but how do you know that the soft tissue is not additional foreign material? Well, you really don't. Mm-hmm. So if you were really, really crazy, you could fast the cat for 6 to 8 hours and then repeat the rads and make sure that stuff is kind of moving through. But we suspect that at least some of it will move through because it's in the colon and in the small intestine and so on. So I don't know. Some enterocolitis, maybe from eating something it shouldn't. Anything else? Infectious, parasitic,
I got nothing.
Inflammatory.
Boring.
Okay.
Yeah.
Diffuse moderate amount of food and gas throughout the GI tract, but doesn't look obstructive. Lots of fat. Yeah. Mm-hmm. Okay. Some of these are boring, right? But that was one we read off the list. Okay.
Nice.
What should we do? Should we do another one off the list, or should we?
We also take requests, potentially for next time. Like we'll take requests. No, but if there's a specific type of a case you want to look at, or you're like, I'm really struggling with abdomen, or I don't know what a linear foreign body looks like. Mm-hmm. I have no idea when something is a fracture versus like a superimposed mock line. Whatever your requests are, you can throw those in, and Peter may or may not address them, depending on his mood.
I probably won't.
Okay, great.
I'm kidding. 3 views, chest, 4-month-old Westie. Based out of California. The Westie was shocked by an electrical cord.
Pulmonary fibrosis? Is the Westie clinical?
Is the Westie clinical? I don't know, Doc Allen. You tell me. What do you think? Do you think the dog's clinical? What do you think?
Diagnosis puppy.
Let's see if Dr. Allen will stick her neck out and tell me if the dog's clinical. Do you mean electrocuted? Yeah, the dog was electrocuted. What did I think I said shocked?
Yeah.
That's true.
Electrocuted is more scientific, maybe.
That's good. Maybe it's a scary Halloween decoration. Okay. Touche. Yes, the dog was electrocuted. Okay, so it's the Westie clinical. This Westie, based on the rad, is not clinical. So Dr. Allen's asking about clinical, no evidence of non-cardiogenic pulmonary edema. That's right. They took this. They want to see, does the dog have a caudodorsal lung pattern? One of the differentials for non-cardiogenic pulmonary edema would be an electrocution. And this dog doesn't. The dog did, however, eat a ton and then went over and chewed on the cord. But they're not giving us any indication that he's having signs of food bloat or GI sign. So even though there's mineral chunks in there and that stuff that he shouldn't have eaten, I don't know. I'm not going to really. What I'll probably say in the report is, look, there's a lot of stuff in the stomach. I mean, this is all stomach. I guess I shouldn't assume that people see what I'm saying. This is the stomach. This whole thing right here. This whole thing right here. This bag right here. It's all his stomach. So it's a massive stomach in this puppy, and there's mineral. So fluid, mineral, soft tissue is a huge stomach. So you're not wrong.
Is it barfing? I mean, is it barfing? If not,
it's not. No, it's not. So
it's not barfing. I think it's interesting. Yeah, I mean, the puppy's obviously eating a cat litter or something to that effect. But I think, well, now that you've closed it, it's all right. But I was just going to point out size of the liver, and somebody else had mentioned poor abdominal detail. Yeah, I think a couple of things. So the liver, I think the liver in puppies and kittens tends to look a bit larger than in adult dogs. So that's something I would just blow off as normal. And then serosal detail in this case, there's a couple of reasons why it would be decreased. One, because of the age of the dog, possibly, and two, because that stomach is creating a mass effect just because of its size, and so that will decrease serosal detail as well. Yeah, so I agree with you guys. I'm not excited about that chest.
Okay. Yes, not excited. I wouldn't say unremarkable, because then you could quip, why are you remarking on it? And
Sure.
I like that.
It's a good point. I do it all the time anyway. Like, I know I'm doing it, and then I still do it.
Yeah, there's a book. Let's see if I can find it, called the RAD Report.
Like, I'll mention 14 organs and then say the following 17 things are unremarkable.
Right.
Yeah, I do it all the time. Yeah.
All right. This is let's see, 554 496 554 554. There we go. Okay, this is a fun game. 4 rads of a cat. Okay, this one's going to go kind of quickly, because I'm just going to ask you to try to decide if you think this cat is presenting for urinary signs or GI signs.
Okay. I feel the pressure. Go ahead.
I know the answer. God bless Dr. Lieberman. Just going for it. I love it. GI.
Right.
GI. Okay, so a couple of things I think to point out. Just anatomy. Cat, long lumbar vertebrae. Okay, kidneys. These are normal. I love looking at cat rads, especially like fat American cats, because you can see everything. So kidneys, I think, are fine. Urinary bladder is fine, which is why everybody's saying that the cat, they're worried that it's got a GI problem. The caudal thorax is fine. The spleen, I believe, comes way down here. So this is the iliopsoas, the filet mignon. This is the splenic tail. I think the spleen's kind of chunky. I didn't tell you the age. The physes are closed, maybe sedated because he's unruly. Liver is still kind of sharply margined. This is the stomach, full of food? Question mark. Here's the colon, full of formed feces. So you can infer maybe this is an acute process, whatever it is. These things trouble me, and I don't know if I found a report. And Marina, feel free to chime in. These stupid things right here. So you'll see a lot of times in fat cats. Sometimes you see
I love it.
These opaque, undulating bands that flirt with the kidney. They're parallel to the spine. They're superimposed with the retroperitoneal space. You freak out that they're hydroureter, a dilated ureter.
Don't freak out.
But sometimes you can't tell, and then you give this wishy-washy report. But for those of you putting it on your radar, you'll see these opaque. Here, you can kind of see one right here. It kind of goes away, but there's this opaque band, and sometimes you'll see them and they'll be big, and you'll think that it's a dilated ureter. So this cat is presented for urinary.
I call a ureter in a fat cat, like that you can just have increased conspicuity of that ureter because it's surrounded by so much retroperitoneal fat.
Yeah.
If it was big, I would worry about hydroureter, but if I can see it and the cat is fat, I just call it money.
Yeah. Okay. I like that.
Okay.
Sometimes I've heard people talk about fat, like fascial planes that you'll see in really fat cats. Sometimes you'll see them because I've noticed that sometimes these will go cranial to the kidney.
Oh, fair. Then ureter out.
And then I'm like, well, that's a weird ureter. Looks like the cat is just enjoying his food. Yeah, I would. So the reason I wanted to put this up is because I do think it can be difficult I do this game myself. You as a clinician will already know, you won't be able to have the benefit to do this, or because you'll know the history on your own patient. But I like to play the game, is it urinary or GI? So I'll click open the case and I'll just try to decide, especially in cats, urinary or GI, urinary or GI. And it's really, I think, kind of hard. But once you do it enough, you sort of realize all of the patterns of GI that you should just chill out on. And this is a cat with urinary signs. He had lower urinary signs, stranguria, periuria, plaquuria, hematuria. You got any other ones? No,
That sounds good.
Yeah. And so this is a normal postprandial abdomen is the diagnosis on this. I don't see radiopaque cystic calculi. You can sometimes see, make sure to look through the obturator frame, and especially if it's perfectly straight, which this one is. Some good technicians, probably a nice cat, the whole thing. So normal postprandial abdomen. So that's the take home. Any questions, concerns, comments?
I think sometimes, one of the things that can be tricky is linear foreign bodies can be kind of overdiagnosed a little bit. It's kind of like right-sided heart enlargement. I think people tend to like throw that out there more often than is actually the case. And so when you get this like pearls on a string appearance to the bowel in cats, where it's kind of looks hyper-segmented like that, I think that's just normal peristalsis in a cat small bowel, in case anybody was thinking that, which clearly the cat doesn't have.
Okay. I like it. Next case, we're going to do 3 views of the abdomen. We're going to do urinary or GI in this cat. Amelia thinks GI. Yeah, this is GI. So what are the abnormalities that you're seeing? I think great case of the kidneys. Again, fat cat. Okay, here's one kidney. There's the other kidney. There's no third kidney. This is what we say in Indiana. This is the splenic head right here, Marina. Right?
I thought you were in New York. Hold on.
I just moved, but I'm from Indiana. What did you call this?
Craniodorsal extremity, and then the tail is the caudoventral extremity.
Is this a
That's a pen thing.
Is this a pen
That's
thing?
a pen thing. Yeah.
Let's just name it something different. I didn't pick up on that. So the kidneys are fine. Here's colon through here. Here's the urinary bladder here. That may be, here you'll get a little bit of superficial inguinal lymphadenopathy if you're lucky. It's a young cat. I think it's going to be a young cat because you can hallucinate that maybe these caudal end plate physes are
tiny bit open.
They just, they're trying to shut, which in a cat doesn't always follow the rules. It could be maybe still 2, should be 1 or older than a year. But anyway, so liver.
It's experienced overnutrition for its age. Let's just go with that.
He's eating well.
Yeah.
Well fleshed. Big old stomach. Okay. Great example of the right lateral versus left lateral phenomenon with the gas and fluid. So here's a gas cap. Here's the pylorus on the right lateral view, has fluid. You flip the cat over. Left lateral view, gas-filled pylorus because everything went up to the fundus. Okay, but looping, stacking. This is a linear foreign body. I mean, if you can look through here, you go, psh, 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 but look at all this. This is just, these are not good. This is not good. Linear foreign body. Look at this. This rippling with plication. Rippling is not the word we use.
If only I had a hair scrunchie.
Yes.
And it looks, which is so 80s and is coming back now. I can't bring myself to wear one, but hair scrunchie, that plication, it's just like one. And I don't know if you've ever get into this with people, Peter, but like the difference between plication versus like corrugation. And so to me, this is very clearly plication, like a hair scrunchie, whereas corrugation, I think of like somebody like pushing a sock down, like scrunching down the tube part of the tube sock, and that's more like when you get a corrugated like colon in colitis cases. But this is such a beautiful linear foreign body example, and that's one of the biggest stomachs you'll ever see in a cat. So that's got to scream an abnormality to you. I mean, it's possible the cat could have aerophagia or some other reasons to have a stomach that big, not this cat, but cats in general. But that's so dramatically abnormal to have that much gas and fluid in a stomach. What a nice example of a linear FB.
Yeah, and I think one of the other things too that you is another good physics lesson is you notice that this is black, like Marina's soul, and it's black. Right. because it's full of gas. There's just gas right here. But if you look at this blackness, it's more gray, and that's because it's gas that's sitting on the fluid. And so when the X-ray beam goes through the patient, not only just kind of skirts right through the gas, it hits the fluid, and so you get more of an opacity as opposed to this. So this is a great example of not a stomach that's full of gas. This is not, you don't look at this and go, oh, he's just got a gas-filled stomach. You'd say, oh, there's a ton of fluid and there's a gas cap.
That's right. And when you get that mixture of fluid and gas, especially in a stomach, it tends to have a fat opacity or a fat lucency. So if you compare that to like the shade of gray in the falciform fat area, it's weird because as I'm talking, I can't like move the cursor, right? Because
That's
it's
right.
on Peter's computer. But that's a nice way. Like when you have like fat opacity, it's not the stomach's full of fat. That'd be incredibly weird. Unless the animal ate a ton of chicken fat. But yeah, it tends to be fluid plus gas equals fat opacity.
What else do we show them on here? I think I was maybe an intern and I freaked out. I say this a lot because I don't want people to look stupid, but I thought it was a pyometra. So if you kind of look back and you look at these things right here and they're right here, these just opacities, you see the line right here. And then you see the line right there. So that's, that's the iliopsoas again, the fillet. And so that's kind of up here. It's just a well-fleshed cat.
Indeed. And since you brought up pyometra, my like classic go-to like pyometra diagnosis, if you put that VD projection up again, I don't know if you can, Peter, but if you put that VD, chest. Yeah, so not on this view, because clearly this is a linear foreign body case, not a pyometra, but if you put a VD of a cat or a dog up and you have too many kidneys or what I like to call TMK, that's going to be a pyo. And it just looks like one kidney here, another kidney, and they're in the normal spot and then also all over the caudal abdomen. That's going to be your classic pyo, whereas these are very linear.
Surgery. These are the ones where if you have a technician that does ultrasounds, they'll send you like 20 cine loops because they love this.
Maybe more. Yeah.
Maybe more. And you have to.
I am that technician / radiologist that takes 20 cine loops of this because I love it.
Yeah, shame on you. You just
I know. I'm just clogging up the packs.
Clogging up the packs. I do like the sound that the button makes to click to save. You go click. So I will.
Ding. Yeah, P1, whatever.
I will, yeah.
And that bright hyperechoic line just like dissecting across that bowel as it bunches up. It's just it's so sexy. You just want to keep taking one loop after another.
Well, and we would have if we prepared for this at all, which we don't, and we didn't.
We clearly haven't.
And we won't.
That's right.
We're not going to do any preparation.
Nope.
But if we did, we would have an ultrasound of a linear foreign body.
That's right. We would be like, click here, and then it'd be this perfect cine loop. That's right.
And so you have to wait until next week. Okay. Vomiting. 3-year-old.
This is a dog that's going to image well. Like that is my dream. That to ultrasound. Sorry, if you put a pro on this dog, it would have beautiful image quality.
Anybody see anything abnormal before we kind of show you? I'm not convinced, but I would do an ultrasound. Yeah. So Doc Allen is reading between the lines. She's saying maybe there's a GI thing going on here. My guess is she's worried about these loops, maybe back here. Here's what I
like the prostatomegaly.
Yeah.
The intervertebral disc space narrowing. I like it.
Yeah. One of the things that I thought was interesting about the disc space narrowing is that, damn, that is collapsed. And yet the end plates look so nice. So if you're going to collapse the disc and you get those Sharpie fibers and they irritate and they give you the spondylosis deformans, but if you collapse that disc and you just rub, I would expect some sclerosis. And this articular process joint is a little bit wide. I just found this to be a very interesting finding because your options are, is it disc disease or is it some like I tried to be a block vertebra, but I don't know. I think there's an absence of a caudal articular process joint hypoplasia. I don't know if I put that on my original report. I've noticed that now twice where I re-look at these RAS and I go, uh-oh.
That's a tight read, man. That's tight. I don't know that I would have
addendum
put 3 and 4 together. That's good on you.
This is too wide, I think. So one of the things that I do for trauma cases hit by cars I guess while we're at it, we'll just go down it, is I look at the articular process joints because it requires, you have to like really pay attention. Maybe that's a little, I don't know. Let's not go into
But that intervertebral foramen also is not particularly small for the degree of collapse, right? Which is
yeah.
interesting.
Yeah. So now my brain's going, maybe this is, would we be surprised if we did cross-sectional and this is not disc disease, and maybe it's some sort of, I tried to be a block vertebra, you know, the middle child
Like I was born with this kind of thing.
Yes.
Yeah.
Anthony, my mentor, would call it Lady Gaga. Lady Gaga.
I was going to say born this way.
That's right. So here we go. Caudal chest, normal, right? Left lateral view. Okay. No pneumonia. Liver, nice and sharp right here. Spleen. I mean, you know, a little puffy, but I think that's fine. The stomach, a little bit of fluid, a little bit of gas. I don't know, a little bit of rectangular or rhomboidal. Help me, Marina.
Rhombolicious.
There's some chunk of mineral that's angular in the stomach. The prostate gland is too big. Dog's intact. You scoot this back, you'll see some testicles. The urinary bladder is right here. It's small and fluid opaque. This is colon. Okay. This big C-shaped structure, L2-5, right of midlines, your cecum, ascending colon, transverse colon, descending colon, boom, comes through the pelvic canal. Hips are fine. Left kidney, spleen, stomach. So what I do is I try to figure out what's stomach. That's very clearly stomach. What's colon? This is colon. And then the rest is small intestine. And then we talk about size, course, and content. So everything looks either empty or gas filled. I don't see any foreign material. They're taking gentle turns. That last one that we had where they were really, really plicated, and you'll see small intestine is down here, and it's here, and it's up here, it's over here, this little gas filled structure right here. So it's kind of filling the abdomen, which is what you want. Yes, these are bigger than those. And so then you go, oh, but these are full of gas. They're not that big. To me, this is probably gastroenteritis. I would not cut the dog. In my sort of scale of next test, I would feel comfortable saying, treat the patient. If it doesn't get better in 24 hours after starting supportive care, then you do an ultrasound. I don't think necessarily you need to do an ultrasound right now. You definitely don't need to cut the dog. I don't even think this is a case where you keep them overnight, fluid therapy them, and then repeat the RADs in the morning. I feel pretty confident that this is not an obstructed dog. Hypoplastic rib, lumbarization. Lumbarization just means this thing's trying to, look, he's, you know, oh, so he's got this sort of thing that's wonky development. I wonder if that's wonky development too. So, okay, now I need a beer.
Yeah, a brewski. No, my classic go-to line is consider repeat radiographs versus abdominal ultrasound if clinical signs persist or progress despite supportive care. Right on track with
yeah, I think, I mean,
Dr. Noël. That prostate, I mean, up to 60% of the height of the pelvic inlet can be normal in an intact male, right? I think that was what Feeney published in the 70s radiographically. But that does look too big. Question for you. Have you ever, as a radiologist, seen prostatic carcinoma in an intact male dog? Because I have not.
Well,
in 15 years, I have not seen it.
I've never diagnosed that. And my guess is that it exists, but that maybe
it's just a one-off. I just was curious because I've only ever seen it in neutered male dogs. Anyway.
No.
But that dog needs a rectal.
Yeah. Mm-hmm. And this is where I would just probably blow this off. And for me, I would say you didn't tell me anything about lower urinary signs or abdominal pain or anything like that. Could it be prostatitis causing vomiting? I guess, but how often do you have prostatitis without urinary signs? That would be just imagining what that would be like. I think that would be odd. So
no, that's fair. I mean, I know human radiologists that won't comment on stuff that has nothing to do with why the films are taken. I mean, I'm not that guy. Yeah, I'm not that guy. I'm not a guy at all. Not that there's anything wrong with being a guy, but like if I see stuff that has nothing to do with why the animal came in, I will always comment on it. And in the recommendations, I usually use the caveat, if clinically appropriate, right? Or if
Mhm.
clinically relevant. They'll say, consider prostatic ultrasound if clinically reasonable, or, something to that effect. Because you don't want to be like recommending, diagnostic imaging of the elbow if the dog's in for vomiting and it
Well, and
has no lameness.
you don't need to image this back. Don't
Right.
image this back. Don't waste the money. Don't image the
Nope.
back. The dog's dragging his legs. He's painful. Image the
Right.
back. But
Right.
don't. Yeah.
There it is. Okay.
Okay. So 3 views of the
All right.
thorax. Oh boy, a lot of additional tests, but this dog is lethargic and he's coughing. Okay, and there's a
Is
lot
this
of
known case rounds? Is this known
this
cases?
one. I kind of know what's going on. Yeah. So
No, it's great. That's
well, it's
great.
not as fun for me. It's not as fun. But I'm going to give you a 30-second. No, I'm kidding. I'll give you a minute. This is a hard case. I would say this is a hard case. The difficulty is high, mainly because there are a lot of abnormalities.
I love it.
So good luck.
I'm gleeful. Okay.
I expect Urinary to be to get them all right. Lot of things wrong. This dog's in trouble. Oh gosh.
His name is Lucky, by the way.
No, it's not.
Healthy? I think if you name your dog Lucky, you might as well just name it Healthy. It's the
Skip.
worst move. Sorry.
Yeah.
It's the worst move.
Ooh, Uri's dropping bronchiectasis bombs. Boy, oh boy. So bronchiectasis, right, for the uninformed, is you can have different types. You have different types, but you have an abnormal dilation of the bronchus toward the lung periphery. And once you have that, boy, you're in trouble. It's not good.
I see that a lot in dolphins for anyone who cares. A lot of
Bronchiectasis?
bronchiectasis. Oh, all day long, all night strong. Yeah.
Is that what causes that? Same thing?
That's another show. That's another show. It's a whole
Well,
other
I want to
episode.
learn. So tell me something about, is it plastics? Is it the microplastics? What's causing?
It's it's the toxins and it's the PBTs in the blubber. Okay, tracheus deviated alveolar pattern.
Here we go. I'm going to tell you what I read this case out, and I read it out relatively recently. But it's a case that's come back and back, and so we've been able to track it, get follow up, which is great because then you realize, are you right? Are you wrong? So I try to. You can always develop your own pattern. For whatever reason, I like to look at the things that quote unquote don't matter or shouldn't matter, even though when they pop up the radiograph and you look at it, you kind of start going nuts with all the things, but I just go straight to the abdomen. I don't know why. The liver, the cranial, the access is kind of whatever. The liver's fine. Okay. Even though it's maybe a little bit cranially positioned and it kind of feels skimpy, I bet it's fine. The spleen, I bet it's fine. When you rotate a dog like this, so this dog is rotated, he's less rotated. I feel like you'll see more spleen, and this is the body. And so it'll just look a little bit chunkier. But to some of the things that people are saying. So there was discussion about the trachea or the trachea and its position relative to the heart. So this should get you going right here. This opacity, it's superimposed with the cardiac silhouette. So I don't really, what you see is more of its influence. So if you hallucinate, hard to see over here, but when you come down here, there's a wall right here, and there's the other wall. So this is the trachea. So if you follow this, the air comes down here, or the vomit, whatever you're doing, comes down here. The trachea comes down here, hits the carina, right cranial lobar bronchus, right caudal, left caudal, probably the left cranial. So this left cranial is what, so this thing is being pushed over to the right, or it's deviated over to the right. You can be pushed or pulled or not propped up. I feel like so there's a heart-based mass effect. This, I would say, I think I always wanted to have on a lateral view when I started. I always wanted the trachea to do this. You wanted it to literally just get smashed up and have it be really obvious. And that almost always is not the case. I think one of the things that you should keep in mind is normally the trachea will come in and it will kind of dip. So sometimes the absence of the dip is enough to say, like, ooh, why is that not coming down? Could it be fat? Could it be head positioning? Could it be blah, blah, bulldog?
Yeah, I'm glad you said that, because head and neck position can dramatically affect,
yeah,
the course of that trachea.
And that's why we talked previously about the need to get excited when you see something on orthogonal or 90 degrees to views, because things can look crazy on one view and then it kind of goes away. So a lot of times I'll see dorsal deviation of the trachea at the heart base on a lateral view, and then the heart base is totally normal. And this is a case where it comes up and then it's subtle, but it dips up. Should you get totally excited about this view? I mean, you should go, wow, that's interesting. Let me look at the dog on this view. Wow, that's less interesting, but he's rotated, so you have to take it with a grain of salt. But then you go, oh, wow, there's something going on here. It deviates this. So there is a heart-based mass. I looked at the comments again. Doc, help me out. What was I saying? I don't even
Oh,
remember.
yeah. Sorry, I looked at the comments also because I thought
Okay,
part
well,
of my job was to keep those coming. But
there's no
part of
jobs.
what he was, I know, part of my job. No, but I think what Yuta was saying, like if the position of the head and neck can affect the appearance of the trachea on the lateral, yeah, it shouldn't do that on the VD, which was your point that they're, on the orthogonal projection that things are, displaced from where they should be.
Yeah. The other thing to keep in mind too is, I think it's important to, and this is maybe some nuance, but is this at the heart base or is it in the cranial mediastinum? Right. So you start thinking slow growing, maybe chemodectoma at the heart base, neuroendocrine tumor, ectopic thyroid. The dog's he may die of something else. Versus is it mediastinal where you're talking thymoma, thymic lymphoma, maybe something more sinister. And so I think it can be important to try to tease those out. And this is, I think, very clearly at the heart base. Sometimes if there's a big enough cranial mediastinal mass, the trachea, maybe you get this bend further forward, further cranially in the chest. So there's a heart-based mass. There is an air bronchogram right here. So this is enough funk in that right cranial lung lobe. I was confirming left. So plus that right cranial lobar bronchus comes out pretty straight like that. It tapers, but not a ton. So I like this discussion about bronchiectasis because it doesn't really.
It's too big down there in the periphery. It's too big, and it's like blunted at the end. And
yes.
I like the trees and the fog for anybody that hasn't heard that that expression. But people miss air bronchograms a lot.
There's a lot of fog in England, right?
I mean, it's a foggy, like a bone chilly kind of a humid, cold. I don't know what I'm talking about. I've only ever flown through England, never really spent time there. But
this is pneumonia until proven otherwise. Could it be
Indeed.
atelectasis? Sure, whatever. But I think we should talk about pneumonia, bronchiectasis. So you're going to have recurrent pneumonia. The reason you talk about atelectasis in cases of bronchiectasis is they will be prone to having collapse. Sometimes you can get I don't want to go into whole traction bronchiectasis, but this I think is probably bronchiectasis with some low-grade pneumonia. I think this is the left atrium. So I feel like if you come all the way up here and you go like that, this is the left atrium, right? It's not the rib. It's the left atrium.
Is that a little bit of an accent that just snuck in there? Okay.
From
you.
Yeah.
I thought it was. Okay.
What kind was it, you think?
All right. I'm waiting for you to hit the other stuff. I'm just waiting. I'm biding my time.
Yep. She's going to make sure I didn't miss anything on my original read. Maybe this is what we do. This is what I said, Marina. Did I miss anything? This is left atrium here. I think it's interesting how it's much easier to see on this right lateral view. Okay. Less so on this view, probably because he's rotated, but this is the left atrium. Okay. So the cardiac silhouette is too big, left atrium too big, heart-based mass, bronchiectasis.
Hello.
Collection of pulmonary nodules right here.
We've got some friends in an intercostal space.
Yeah. So right lateral view. You can describe these in reference to the cardiac apex, the sternobra, the intercostal space. These are quite small, so I wouldn't be surprised if I couldn't see them. It's a right lateral view, which means we should predominantly see them on the left lung. This is getting near the junction of the caudal subsegment of the left and the left and the cranioventral aspect of the left caudal. So it's probably, I don't know.
Let's look at it. Let's go to the videotape.
I don't know.
The VD.
I don't know if you can see it, Doc.
No, you may not.
I think you can. I don't know. And I guess I'm not surprised because when they're small, maybe they're midline, whatever.
Sure.
You're not going to see them.
I mean, here's the thing. Can you go back? Yeah, right there. That's based on where it is. It's kind of Yeah. If it was a little bit more dorsal, like right in the middle of the chest, then it would be nice and lateral for us on the VD or the DV view, which it isn't. But
Mhm.
can you zoom in a bit on the VD on that right lung? Just like that lung parenchyma
Mhm.
in the right, yeah, costophrenic angle, and I just don't love that. I don't love it.
Yeah, I don't either. I think I don't.
I don't like the
Mhm.
conspicuity of the vasculature versus like the
So
lung
you're
parenchyma.
going, you're like, is the dog in low grade failure? That's where you're
Yeah,
going?
I'm just going, I don't like it. It's not normal.
Yeah,
It's AB normal. It's like
yeah,
diffusely AB normal,
yeah, yeah.
abnormal,
Mhm,
lung parenchyma, in addition
mhm.
to the 87 other things you already described.
So one of the things that I think we could do for is that a Mickey Mouse VD? Dr. Walsh loved the um,
What does that mean?
Mickey Mouse has VD.
Yeah, I don't
He
know
has
that one.
his vanilla. Are you just wanting me to say it, or you don't know?
No, no, no. I don't know what that question means.
Oh, so Dr. Walsh, last time we had a discussion about discerning VD radiographs versus DV radiographs, and I
Oh, I
said
see.
that
I see. I see.
Mickey Mouse has VD,
Got it. Got
and
it.
this is a VD radiograph. And depending sometimes on the positioning of the patient and the beam, Dr. Walsh wrote me an email. Sometimes, depending on the positioning uh, of the patient relative to the beam, you can actually have one dome on a VD view when you thought you should have three. But this does have a little bit of a hump like that. You'll know a DV view. I think maybe I have a.
I also like to look at the caudal lobar vasculature to try to distinguish VD from DV. So the caudal dorsal or the caudal lobar vasculature is going to be more readily seen on a dorsal ventral projection,
Mhm, mhm,
because you have more inflated air-filled lungs surrounding that vasculature on a dorsal ventral view where the dog is on its sternum. And I also think VDs in general are nicer and better for looking at lung, and DVs are nicer and better for looking at the caudal lobar vessels. So it tends to be a preference, not always, but preference for radiologists to like the VD or the ventrodorsal with a dog in dorsal recumbency, and cardiologists like the DV, which is the opposite.
and UC Davis likes all four views.
Sure, sure they do. I did in
And I,
fact go to that school. Shockingly.
that's why I mentioned it. That's why I mentioned it. There's a lot of diplomas on the wall. I think I see it.
Listen, these are all fake. I just got
Oh,
these
it's
on
just
Amazon.
okay. Chat GPT, give me a diploma from Davis.
That's right.
To the
Schwarzenegger signed my diploma because he was the governor when I was in vet school, which is just the best.
I don't believe you. Is it behind you on the
Hashtag
wall?
Schwarzenegger. Yeah, I'll drop a JPEG into the chat at some point. I
Okay.
approve.
Yeah, I don't believe you. Okay, no. So to the point about the VD versus DV
Yes.
view, uh, if at all, you look at this radiograph and you go, man, there's a lot going on. I wonder if the dog does have left-sided congestive heart failure. You could do a DV view to try to pick up on low grade failure. But what I'm going with is moderate generalized, predominantly left-sided cardiomegaly. I think without cardiogenic pulmonary edema, there's a heart-based mass. There's right cranial lung pneumonia with bronchiectasis. There's a collection of pulmonary nodules. So tying a bow on this, I'm wondering if this heart-based mass is in fact malignant, causing regional Mets. Maybe the dog's got this bronchointerstitial pattern because he also has lower airway disease like allergic bronchitis or pulmonary fibrosis, though it is more bronchial than unstructured interstitial. And maybe that's why he's prone to this pneumonia. Maybe he had, check this out. Maybe he had, the reason I got excited because it's a differential besides pneumonia and atelectasis. Maybe he had radiation therapy
Oh,
and blasted that lung tissue, and now he's got like a toxic pneumonitis.
oof. Look at you out there on a
I
ledge.
don't know. I don't know.
How does it feel out there? Do you need a hand? Do you think
Um,
there is an alveolar pattern in the left cranial lung too, Dr. Curtin or Kirtan? Curton? Kirton, si tu veux.
okay. Was that so? Do
I
you
think
speak? You speak French?
un petit peu.
Okay.
Okay. So
I can answer this question, Dr. Curtin.
please.
This
Yeah.
dog does not. You're looking at this right here, and you go, ugh, and then you're going like this. This is this. It's just on the other side. Let me make sure I'm not making this up. I don't think I am. Do you see how this is like vague looking? There are two things that caught my eye. The first is that bronchus kind of looks like that bronchus. This looks kind of vague, and this looks more right in here, really opaque. This also looks more dorsal relative to that, if you feel me on this. So this funk and this bronchus are kind of down here, and this, it kind of looks like it cheated up a little bit. And the reason is because it's in the right cranial lung lobe, and when you put the dog on the right side, chest down, that lung kind of tends to retract up towards the hyla. And
Sure.
then when you fire the rad, it looks like it's more proximal or dorsal rather. So this, I believe, is just this. So here we go. I think we're done. I'm done. I need dinner.
Yeah, sure. I got to go see my little one.
Okay. So everybody, thanks for tuning in.
Yeah.
We'll see you next week.
Wait,
we may adjust.
We did the balloons. Yes.
There's not an alveolar pattern there, so it's normal. Okay, sorry. I need to clear up, Doc. So
please.
This dog has an alveolar pattern. It is in the right cranial lung lobe. I think the dog has right cranial lung pneumonia with right cranial lung bronchiectasis. I am not convinced that the dog also has left lung pneumonia. And the reason is because I think that bronchus is belonging to the right cranial lung. Mainly because it comes off at that angle. The left makes this sort of J hook. I'm making it more complicated. I'm going to leave it there.
Yeah.
Anyway, so we may do it. We may adjust the time next week. I'll email you guys. Make
Victoria's
it earlier.
hoping not. Victoria's saying please
Victoria,
don't. But,
thank you. I do like the time.
God bless. Thank you guys for that.
She's in Florida.
Yeah, I was just in Florida last week. All right.
Scanning a dolphin. All right.
Shout out Florida. Okay.
All right, everybody. Talk to you next time. Bye.
Oh, thanks everybody. You guys are the best.